Welcome to the Stanford Clinical Lecture Series in Radiation Oncology. Доброго вечора, українці. Here's the slide for Stanford physicians. Stanford physicians can apply for Stanford CME credits. I will also post the text number in the chat. And for Ukrainian audience, please make sure that your name in the Zoom meeting matches your formal name, because we are tracking your attendance, and at the end you will have a certificate of completion with a number of credits equivalent to attended lectures. And also good news for Palo Alto Stanford faculty and staff. The department is sponsoring lunch for us today, so we'll be provided next to the classroom. So today's lecture is on gynecological high-dose rate brachytherapy, and we have excellent speakers today, Dr. Elizabet Kidd and Dr. Thomas Niddermaeyer. They are both associate professors at Stanford, and they are a great team who pioneered 3D printed patient-specific brachy applicators for GYN cancer treatments. And they have published numerous manuscripts and gave many lectures at conferences and invited visiting professor talks in US and also in Canada. And they are both excellent teachers, having received multiple teaching awards from Stanford, and for Thomas also from Stanford and Harvard residents. So welcome, both of you. Thank you for teaching us today. And Beth, please take it away. I'll stop sharing.
All right, so hopefully you see my slides now.
Yeah, we can see your slides.
Great. So we're going to talk about gynecologic brachytherapy. So just a little overview. We'll start off with a little bit of background about brachytherapy, and then talk about vaginal cylinder, tandem and ovoid, and interstitial brachytherapy. So just to start off initially with a question, what is brachytherapy? And I think Natalia will share the poll so everyone can vote. So a special type of training to ensure everyone takes adequate breaks, a new type of radiation used only for gyn cancer, a type of radiation where radioactive material is placed within or in close proximity to the tumor, biologically guided radiation therapy, or a special type of external beam radiation similar to external beam. I don't know if where do we see the results? All right, very good. So yes, the type of radiation where radioactive material is placed in close proximity or within the tumor. So just kind of showing this, you know, since we use a radioactive source for HDR, iridium-192, and it has a really sharp dose follow-up as shown here comparing to electrons and photons. We currently have the Bravos afterloader, so the radioactive source is contained within this and then has all these different channels for allowing the treatment. So a very small radiation source that can go within applicators. And so kind of contrasting brachytherapy with external beam. So with external beam, right, that the radiation is coming from the outside and passing in. And even though you can deliver a very high dose to an area, there's going to be a lot of dose to normal tissue where the radiation passes through. With brachytherapy, this is showing a tandem and ovoid, and then this is showing a cylinder. The dose is coming from within and emanating outward, and has a pretty sharp fall off. So you have a really hot dose within or close to the applicator, but then the dose really falls off so that you're giving a lot less dose to the normal tissue. So for gynecologic cancer, this works out really well with the anatomic areas that we need to treat, whether it's the cervix area or the vaginal canal. So brachytherapy is a type of radiation that actually uses a lot of people. So we have the attending physician, the resident, the medical physicist, radiation therapists who specialize in brachytherapy, dosimetry to do planning, so similar to external beam, but for doing the planning for brachytherapy, nursing to help with the patients being comfortable while we're doing these procedures, since they're, sort of somewhat invasive or, procedure. And then sometimes we also use anesthesia, depending on the type of procedure we're doing, and then also potentially radiology. So we use ultrasound for all our procedures, and we actually do those without radiology, but we use radiology when we're doing MRI, in particular for our tandem and ovoid or interstitial procedures. So there's also a lot of equipment or things that are involved. So besides the afterloader, so there's transfer guide tubes, which are tubes that connect between the afterloader and the applicators. And then there's, the different applicators. So the vaginal cylinder applicator, like a tandem and cylinder applicator, tandem cylinder plus interstitial, tandem and ovoids, tandem and ring, and then equipment to help you to be able to do the procedure. So whether that's, speculum, so that you can visualize the cervix or better visualize the vaginal canal, or gold seeds if there's areas that you want to mark, or other equipment to help you with the procedure, such as retractors or forceps. So there's a lot of equipment involved, besides also a lot of different staffing. So talking about vaginal cylinder brachytherapy, who of the following is not involved in vaginal cylinder brachytherapy? So clinical nurses, brachyradiation therapists, resident physician, MR radiologist, or medical physicist. So let everybody answer, and then we'll see the poll. So there's the poll. Yeah, so the MR radiologist. So for vaginal cylinder treatment, we don't require MRI. So it doesn't require the radiologist. And I guess it doesn't require a resident physician, but generally at Stanford we have resident participation. So then just kind of showing a vaginal cylinder brachytherapy. So, there's different sizes of the cylinder. And generally, we use vaginal cylinder treatment as an adjuvant treatment following surgery for high intermediate risk endometrial cancer patients to help prevent recurrence at the vaginal cup. And so then this is just showing an example plan where a 3-centimeter vaginal cylinder has been inserted into the vaginal canal. Generally, when we do these procedures, we'll do a speculum exam first and place gold seeds along the scar to help us to ensure that, when we're looking later on imaging, that we can see that this applicator is up against the scar. And we'll do a CT scan, and then on that CT scan, we'll also contour the rectum, which, sits behind the vaginal canal, the bladder, which is anterior, and then the little bit of bowel that might be superior. So just some background on, defining the high intermediate risk group that we treat with vaginal brachytherapy. So the main study that we often think about is GOG 99, which included stage 1 endometrial cancer patients who were either treated with no further treatment following surgery or pelvic radiation. And for the whole group, the risk of recurrence at 2 years was 12% with no further therapy versus 3% for those who got radiation. But then they saw that if for this particular group that they defined as a high intermediate risk group, the 2-year risk of recurrence with no further therapy was 26% versus 6%, but I'll give the caveat on that a bit, that it's likely lower than 6% with radiation. And how they defined high intermediate risk related to age, along with these factors listed here. So grade 2 or 3, LVSI, so lymphovascular space invasion, or if there was outer 1/3 invasion into the myometrium. So that if the patients were age 70, they only required one risk factor to be considered high intermediate risk, and then age 50 to 69, 2 risk factors, and an younger age, then 3 risk factors. So then, as I mentioned, in terms of recurrences, so those who got no additional therapy, really the high area at risk is the vaginal canal. So no additional therapy is 13 recurrences versus in radiation, there was 2 recurrences, but actually the caveat is the analysis was by intention to treat. And so these 2 patients who actually recurred were in the radiation arm, but actually didn't receive radiation. So that's why I said there's sort of the caveat to that 6%. So likely if those patients had actually received radiation, that 6% would be much lower. So I usually, cite, less than 5%. And given that vaginal recurrence was the area of most concern, there's a subsequent study, PORTEC-2, that randomized between pelvic radiation and vaginal cylinder brachytherapy with the thought that maybe we could just treat the vaginal canal and, decrease the risk of vaginal recurrence, but really decrease toxicity. And so this is like the 10-year outcome from PORTEC-2, which shows, similar outcome in terms of vaginal recurrence and no difference in overall survival, but significantly more GI toxicity with external beam, or less GI toxicity with vaginal brachytherapy. Additionally, kind of in the interim of while that study was being conducted, there was other studies being done that were kind of looking at the significance of molecular classification in endometrial cancer. And that's actually even emerging more so of being really significant. And so what they found was that there was kind of 4 different molecular groups. So the POL-E group, which shows a really favorable outcome, and then kind of 2 intermediate groups, the MSI, or mismatch repair group, as well as the no specific molecular phenotype group, and then the more unfavorable group, which is like serous-like or P53 mutated group. And so the PORTEC-2 group looked at those same molecular patterns and saw that their population followed kind of that same grouping, with the POL-E being really favorable, no specific molecular phenotype, and mismatch repair group in the middle, and then the more unfavorable outcome for the P53 mutated. And then the other thing that they found was that there's actually an increased risk of pelvic and distant recurrences for patients who receive vaginal brachytherapy and if they had a P53 mutation or a substantial lymphovascular space invasion. And so they made the recommendation that for those populations to consider external beam instead of just vaginal brachytherapy, given this high risk of pelvic and distant recurrence. So that's something to keep in mind. And then who else do we treat with vaginal cylinder brachytherapy besides the high intermediate risk group? So it also can be given as a boost, so in addition to external beam radiation, for endometrial cancer patients with maybe higher risk disease, and in particular with cervix invasion or other risk factors. So if we're giving pelvic radiation, maybe because they're stage 3 disease and they also have cervix invasion, or for high risk post-op cervix patients who maybe have deep invasion or a close margin or things like that. And then we also would think about giving that for primary vaginal or recurrent endometrial cancer patients who have residual disease less than 5 millimeters thick. And then this is just the data from a population-based study showing the 5-year survival benefit for patients who got the combination of external beam and brachytherapy, in particular if they had cervix invasion. And then how is vaginal cylinder brachytherapy done? So it's one of the quickest courses of treatment for radiation. Generally, we do 3 vaginal cylinder treatments with a max of 2 treatments per week, not 2 days in a row. So you often hear we do like Tuesday, Friday, Tuesday. And then usually we say the patients will be in the department about 3 to 4 hours. It could be less than that, maybe it could be, on the order of like 2 hours. So they arrive, they get some pre-medication with a pain medicine, relaxing medicine. We have a Foley catheter placed. There's kind of a couple reasons for that, right? With the vaginal canal, the bladder sits kind of very close to that, so we want to help empty out the bladder. And then also once we've placed the applicator, the patient has to, keep laying flat, and that way the catheter will help empty the bladder if there was any urine that developed while we're doing the imaging or the planning. So after we've done that, on that first visit, like I mentioned, we would do a speculum exam and place gold seeds along the scar, and then we place the applicator. And then we do a CT scan. And what we're looking for on that CT scan, again, is making sure that the applicator is up against that scar, so up against those gold seeds. And then we also use that CT scan for making our treatment plan. So we contour out the area that we want to treat, that upper part of the canal, to the depth of 5 millimeters, and then also those normal tissues like the bladder, the rectum, and the bowel. And then we make a treatment plan, do some QA and checks, and then give the treatment and remove the applicator and the catheter, and the patient goes on their way home. So just to conclude about vaginal cylinder brachytherapy, it's a treatment that can be done as an adjuvant following surgery for high intermediate risk endometrial cancer patients. And then also can be given as a boost treatment along with external beam for patients who have other high-risk features such as cervix invasion, or for high-risk cervix patients in the post-op setting along with external beam, or for patients with primary vaginal or recurrent endometrial cancer, who after their external beam, their disease is quite small, they're quite thin, less than 5 millimeters thick. So which of the following is true about tandem and ovoid brachytherapy? So we're going to talk about that next. So no anesthesia or pain medications required. Patients are required to stay overnight in the hospital. It is generally given as the only treatment for cervix cancer. SBRT is a modern substitute treatment, or image guidance is an important aspect of modern treatment. And then we'll see the response soon. Yeah, so the majority of people got the correct answer about image guidance is an important aspect of modern treatment. And then shortly we'll talk about how SBRT is not an appropriate substitute, and that generally external beam is combined with brachytherapy. And usually patients do require some sort of anesthesia or pain medication. So for intact cervix cancer, why do we do the combination of external radiation and brachytherapy? And it really has to do with, that we're going to get better outcomes with that. So this is actually older data from MD Anderson, where they looked at, the central pelvis dose with external beam. So meaning if there's a lower central pelvis dose given with external beam, there was a higher dose given with brachytherapy. And they see with a lower dose, there was better disease-specific survival. And there was less toxicity or less complications. And it really, again, relates to the anatomy and the amount of dose that you can get in. So it's just showing kind of your typical pear-shaped dose distribution from tandem and ovoid brachytherapy. Additionally, there's population-based data that unfortunately shows a decreasing use of brachytherapy with a corresponding increased use of increased use of SBRT and IMRT. Likely due to, practitioners being less comfortable with brachytherapy or less experienced with brachytherapy, but using IMRT and SBRT to treat a lot of different types of cancer. But unfortunately, there's a real detriment to survival for patients who get SBRT or IMRT as opposed to brachytherapy, as shown here, and actually more detrimental than not receiving concurrent chemotherapy. So it's really critical for curative treatment of cervix cancer patients that they get external beam and brachytherapy. And there's been a lot of advances in how we do brachytherapy. A while ago, there was just sort of 2D imaging with X-rays. And now we use, 3D imaging with MRI, which allows us to see not only the normal tissues in the applicator better, but also the tumor. So with using MRI, we can see, the area of residual cervix tumor, and then, make sure that we're really encompassing that with our treatment. And a lot of this use of MRI and image guidance has been pioneered by the JEC-ESTRO group. And so they help define, these MRI-based volumes that we should be thinking about. And it really relates to kind of the macroscopic tumor load. So, the gross disease that you have at the time of brachytherapy, there's probably a high volume of tumor. At the same time, where the tumor was when you started all your radiation, so before the external beam, also probably has, a certain volume of disease. So you want to think about treating that area as well. Additionally, besides giving recommendations about dose to the tumor and target regions, they also give recommendations about dose limits to the adjacent normal tissues like the rectum, the bowel, and the bladder. And in particular, when you think about it, with the dose emanating outward from these applicators of the tandem and the ovoids, we worry about kind of this posterior bladder area, anterior rectum, and then potentially some of the sigmoid or bowel. What they've also helped to show is, how patients do. And so they found that, larger tumors or more advanced stage have worse outcomes. So this is just showing, the 1B, 2B, 3B, have worse outcome. And it could relate to sort of how the standard, brachytherapy dose looks like. So as I mentioned, with your standard tandem ovoid dose, you kind of get this pear-shaped dose distribution. And if you have, kind of a large tumor, there might be areas of the tumor that aren't getting that full prescription dose from your standard dose distribution. Additionally, what the JAK ester group found was that, patients who had large tumors, so more than a 30 cc tumor, patients were treated in different ways. Some groups just used intercavitary alone, so that's tandem and ovoid only or tandem and ring only. But some groups use intercavitary plus interstitial, so meaning tandem and ovoid plus needles or tandem and ring plus needles. And what they found was that the groups that used the combination of intercavitary and interstitial were able to get a higher dose to the high-risk CTV and also showed better local control, in particular for these large tumors, without any increase in normal tissue toxicity, so that large tumors could be better controlled with the addition of needles. Kind of to help explain this, when you look at how, this is just showing an axial view of kind of the upper cervix, where the tandem is shown in this bright circle, and then you have the bladder anteriorly, the bowel posteriorly, and then the tumor in green. So if you only have the tandem, the dose comes out symmetrically, sort of as a circle. And then, the challenge is that maybe the tumor is actually wider than it is anterior to posterior. And so you have to balance. If you adequately cover this tumor, you're going to have more dose going into the bladder and rectum or bowel. But if you can just add some needles, sort of in parallel with where that tandem is, you can shape the dose more. So you can, decrease some of the dose that's coming from the central tandem, add some dose to these lateral needles. So it actually makes your dose from the brachytherapy wider to better cover the tumor, but also narrower. So kind of ovalizes the dose. So now we're actually covering the tumor better, but giving less dose to the anterior bladder and the posterior bowel. So all this makes sense. It's like, great, why doesn't everybody use needles? This seems like this is like an easy solution. Well, it does offer a lot of benefits, but it's also very challenging. So, where we're putting the needle. So when we're doing, cervix brachytherapy, we're working within the vaginal canal, which is often kind of a small area. And then there's the tumor there, and then the other brachytherapy applicators. And it can be kind of tricky. So where you want to get the needles, right? It's very helpful to get the needles kind of aligned with the tandem. You know where you want them, but it can be tricky to kind of weave the needles through the other equipment to the position that you want. And so there are some tools that are available, some commercial available templates that help with placing needles. They tend to be vendor specific. We actually tried some of these. We often found that they were a little bit large for our patient anatomy and didn't necessarily put the needles where we wanted. So several years ago now, we developed these 3D printed templates to aid hybrid brachytherapy. And we called them target or tandem anchored radially guided interstitial templates. So it's a small, 3D printed template that we attach to the tandem where we would normally attach the flange. And then there's a few small holes or needle guides. Because they're 3D printed, those can be kind of curved. And so then we can have the needles be guided to where we want them to go. And then we also work with the machinists at SLAC to create what we call the Stanford swans that attach to the end of the ovoid, so that once we place the needles, they can be secured in that position. So essentially with this target, we sort of replaced the challenge of putting the needles into the tumor with simply putting the needles into the template holes. And so we looked back at our experience about a year or so ago, and we saw that, kind of comparing using the target versus freehand or no needles. And we saw that, the use of the target significantly improved the coverage of the tumor without increasing the normal tissue doses. And so we found that, it was really convenient. And then about a year and a half ago, we actually sort of refined the design. So we had kind of a few different designs of the target that we were using, sort of like some that were wider, some that were narrower, some that included posterior needle positions. And so this refined design that we call Target FX for flexible extended actually has the potential for, or has 9 different potential needle positions, sort of 3 different widths bilaterally, and then 3 different posterior positions. And then the extended aspect, instead of being just at the vaginal apex, it extends all the way to the vaginal introitus, so making it easier to put in the needles. You're not, again, having to navigate through the other equipment. And the flexibility with the different positions, allows us to, modify what we're doing either during the procedure while we're doing the ultrasound, or, when we do the 3D imaging with CT. So kind of just to explain how we do the procedure, so we insert the tandem as normal into the cervical os, into the uterus, and then we slide on the target effects. It slides over the tandem, and then it will go all the way up to the cervix. And then once it's against the cervix, we secure it in that position, and then a portion of it will still be extending out the vaginal introitus. And then we place the ovoids as we normally would, and then we put the swans on the ends of the ovoids, and then we put the needles in the holes that we're planning to use. So as I mentioned, this target effects has 9 potential holes or needle guides. Generally, we use on the order of 2 to 4 needles per procedure, kind of depending on the size of the tumor. So it has these different potential needle positions, but usually we're only using a fraction of those or a portion of those. And then another thing that's kind of nice, so we have the flexibility during the procedure, as I mentioned, but we also have the flexibility after we do, because of it extending out the vaginal introitus, after we do the CT imaging, that it could be, when we look at the imaging and we see the area of the tumor, we're like, oh, it actually would be helpful to have a needle in this position. And since this is extending outside of the vaginal introitus, we can add the needle without having to unpack and remove the other aspects of the applicator to then add that needle, which can be helpful in certain situations. So we recently looked back at our experience, kind of comparing this new design of the target effects to our historical cases that were done with target. And we found a lot of advantages. We found that actually the procedures were about 30% quicker. So they're about 9 minutes quicker, so about 30% quicker, which is nice. And our dosimetry was also better. So our tumor coverage was significantly improved. And then similarly, we didn't have any particular increase or significant change in our normal tissue doses. So we were still able to meet the Jack Estro constraints, despite the fact that we're improving our tumor coverage. So we found that this 3D printed tool really helped decrease our procedure time, really improve efficiency. And at Stanford, generally we have residents, so it also helped with resident participation. When we're doing needles freehand, putting in needles was one of the later stage things that residents could learn to do. But now with these tools, very early on, even sometimes on their first day of rotation on my service, they could be placing needles, which is nice. And then we really appreciated the flexibility of the needle options with the target effects, so that, like I mentioned, we can modify during the procedure, or we can modify after the packing when we do the CT or other imaging. And then we found the excellent dosimetry. We've also found that this design, as I mentioned, we've been using it for about 1.5 years now, works in the vast majority of cases with this sort of standard design. Probably 85% of the cases, the standard design works. But for patients with more atypical anatomy, we actually are able to kind of customize this to kind of, fairly quickly modify a couple of the needle positions, so that maybe if the first procedure we see that this doesn't work, then when we do the second procedure, we already can use a design that better customizes the needle to this unusual anatomy. So kind of we'll just walk through how we generally do the procedures and workflow for our cervix patients. So here we usually have the patients get 4 separate outpatient procedures that are done under anesthesia. We've been really working to minimize or decrease the amount of time the patient has the applicator in place. So we have kind of these different steps, sort of pre-procedure, procedure, imaging, planning, and treatment. So we'll kind of step through all of those. So in the pre-procedure, so for cervix patients here, they'll generally get an MRI before their external radiation that we use to help plan the external radiation. And then towards the end of external radiation, when we're getting ready for brachytherapy, we'll repeat that MRI, because usually the tumor will have changed and often shrunk a certain amount, and we want to see what that tumor anatomy is like now, so we can take that into account. So we want to see the tumor size, we want to see the uterine position and angle, and generally what we do is actually contour out that tumor on that pre-brachytherapy MRI, and then we have scanned our target effects with all the needles in place, and we can fuse that into that pre-brachytherapy MRI. It's not an exact because, sometimes having the tandem in place could change the uterine position, but it does give us some estimation about, what we think about in terms of which needle positions might be most helpful, what depth do we want to place the needle. So we kind of have that information going into the procedure. And we started this pre-planning approach, a year or two ago, and we actually saw that it was particularly beneficial, this really formalized pre-planning approach. And we found that for patients where we did this pre-planning approach, the tumor coverage that we had on the first fraction was actually often similar to patients' second fraction who were not pre-planned, in the sense that it's common that as you do your procedures, you learn, because once you get things in place, you think, oh, this is what I should do for the next one. But with using the information on the pre-planning, we were actually able to, really improve the dosimetry on the first fraction to what we were historically getting on the second fraction. So it's just really great. And then for the day of the procedure, right? So we go into the day of the procedure already with an idea about what we think we're going to do in terms of the applicator we're going to use, the tandem angle, the approximate tandem length, the ovoid size, the needle position, the depths that we're going to place. Although we go in with this plan of what we're going to do, it's not that uncommon. There'll be some modification in what we actually do, and then even some modification in terms of what we think we're going to do for the next procedure to make it even better. So this is one of our procedure rooms. We actually have 2 procedure rooms in our department that are equipped for anesthesia. So the tandem and ovoid procedures are done under anesthesia. They also have ultrasound equipment, and then there's a CT across the hall and an MR next door. So very convenient for all the imaging. And then also we'll have our procedure table set up with all the equipment we want. And then for the target effects, we have this pre-plan about which positions we think we're going to use and the depth that we're going to place the needle. So we'll mark those as well to be ready for the procedure. And then, as I mentioned, we have ultrasound. We have both transabdominal and transrectal ultrasound. We actually more infrequently use the transabdominal ultrasound. This is just showing, in particular, we use the transabdominal ultrasound when we have a cervix that's maybe trickier to get in or it's harder to get in the tandem, that we want to just verify. So this is kind of showing the uterus with the tandem here, and kind of to show like a similar imaging position of, where the tandem is going. But we generally use the transrectal ultrasound for all procedures, for all tandem and ovoid procedures. And we found that it's very helpful, and it gives us a really good look at that cervix tumor area. So, this is with the transrectum ultrasound in place. This dark area is the cervix tumor, and this is just showing kind of 2 different patients. And then this bright white is the tandem. And so when we first, after we place the tandem, we take a look with the transrectal ultrasound to see if things are as we anticipate based on the pre-imaging. Is the central uterine canal in the center of the tumor, or is it more anterior? Or is there anything else about what we're seeing in the anatomy that already might make us change our plan about what we're going to do in terms of the interstitial needles that we got? And then, as I mentioned, we've used the target effects, so slide that on, put the ovoids in. And then as we start to add the needles, we're also looking with the transrectal ultrasound. So this is just showing tandem only. And then as we add the needles, we can see those. And then, as we add them, we kind of see, are they going where we anticipate? Do we need to add additional needles to cover the area of the tumor? And then we go on to other imaging, generally with a CT and MRI. So first we go to the CT, because that's sort of quicker imaging, and we get a quick look at how everything is to see if, when we're seeing the CT imaging, if we're seeing something different than what we were seeing on ultrasound. Do we need to change anything? Do we need to change the depths of the needles? Do they need to be a little bit deeper? Or do we need to add a needle because we see something different? And then usually from there, we do what we call sort of parallel processing again to kind of increase the efficiency. So myself or the resident physician will contour the normal tissues, the rectum, the bladder, the bowel in MIM, while the DOSI team traces the applicators in ARIA. And then the patient goes to the MRI to have, so that once that's done. So for this MRI with the applicator in place, we just do a limited sequence, and then that's fused to the CT, and then we can contour the high-risk CTV, and then this is passed on to dosimetry for planning. And then I'm going to stop sharing and pass to Dr. Niddermeyer for sharing about how we do planning.
So what I'm going to do is I'm going to walk you through the different steps of planning we do by taking an anonymized patient here. This is a variant brachyvision. And what you see here is a CT of a patient with applicator in place. So you can see here on the coronal, you can see the tandem, and you can see here the ovoids to get you oriented here. So the first step is after import, as you heard, there's a parallel process where the dosimetrist will trace the applicator, will tell the treatment planning system where the sources are allowed to stop and go. In parallel, the resident or physician will contour the three OARs, the rectum, the bladder, and the bowel. And the CTV, the high-risk CTV, gets contoured on the MR, which is used on the CT. Once you have all that, you can actually start planning. What we do is we start with history, and we follow the point A initial weighing, so the pear-shaped dosage. So how do you get that? Point A is a point that's defined geometrically as being 2 centimeters up and 2 centimeters to the side from the tandem. And following the rule-based system to get a dose distribution, we have here the time of the source in the different applicators, here in the tandem, here in the ovoids. And what you see is this classical weighing of, you might have seen, of 2, 1, 1, 2, 2. What we're trying here to emulate with HDR is the LDR experience with cesium sources. The cesium source typically was 2 centimeters in length. Here we have a step size of 4 millimeters. So we have 5 steps representing, mimicking an LDR slug that was inserted into the applicator in the LDR time. And so we start with this initial weighing in order to get a pear-shaped dose distribution. The way you do this is you simply normalize to point A, and you get a dose distribution that looks like this. So this is how treatments used to happen. You simply normalize to this point, and you get this pear-shaped dose distribution. So in yellow is the prescription line. Here we get 7 gray, 4 fractions. And in blue is the 200%. So everything within there is 1400 centigrade or higher. So if you look at this, you will see that this is too hot. So I am trying to do this live, so I'm running into some issues. Here we go. So we have here what is called a clinical protocol. These are our dose constraints here. So the typical dose constraints for HDR brachytherapy at the dose to the hottest 2 cc of the normals, bladder, bowel, and rectum. And the constraint metrics that we look for the CTV are the V100 and from the Embrace 2 trial, the D90 and the D90. So red, as you can imagine, means we are over the limit here, and green, we are within our limits. So we have very good coverage here because we have 99% coverage, but we are giving way too much dose here to the bladder and bowel. And we can look a little bit more in detail here how this is really playing out. What you see here in the sagittal view, this dose is spilling into the bladder. So the first step after having done this classical weighing is to manipulate the dose locally in order to reduce the OAR contribution here. So what I'm looking for here is which dwell contributes the most to this area. I can see this because it will highlight the dwell. And I will simply reduce dose in order to have a better contour of the dose conformity with the OAR. I will do this stepwise in order to reduce. Since it is simply a tandem and is symmetric, it also at the same time reduces the dose of the bowel. And I have interactive features in that now I can see that my dose to the bladder has been reduced significantly and is below the actual limit, but the bowel still needs attention. And I can see here, up here, the bowel is still quite hot. And again, I will look where this is happening, and I will reduce my weighing in order to reduce dose to the OARs. Now, the problem is when I do this, I will end up reducing coverage to my CTV. Because now I'm just focusing first step on the OAR. So now I have all the OARs in good shape, but now my CTV coverage has suffered. Right now, I've only made use of my tandem and my ovoids, and I have the needles now that were placed at the time of the implant that I can preferentially add, because now I have geometric locations which might be more beneficial to add. You can see here, there's an axial view. We have the bladder here that we're trying to avoid. We have our tandem, which has a circular symmetric dose distribution. And we'd like to do a little bit better dose shaping. And we can do this by preferentially adding dose locally through those needles that were placed with the target in order to get more degrees of freedom where we could make use of them. So what you see here is if I had made use of the tandem in order to get that coverage, I would have filled the dose into the bladder. But now, because I am I have so many degrees of freedom, I can more preferentially shape the dose to what the tumor looks like. What you see is a complicated tumor because it invades into the bladder. So this is an iterative process here that preferentially uses the degrees of freedom that helps you at the places that you need. So I can give more lateral coverage without going up or down. So this iterative process then gives us the results that we're looking for. We can increase the coverage. We're almost there. I'm not going to go through the full treatment plan here. I'm going to show you what the result is of this. So here's the actual clinical plan. What you see, all degrees of freedom have been taken care of. You can see a nice dose distribution here where it's fairly homogeneous in terms of the use of the needles. So the needles from the Embrace 2 trial typically should account for around 15% from the total dose, or in this case, we do the computation by the total time. So a needle contribution is only added at the end to fine-tune the dose. These are the dose constraints from the Embrace 2 trial. And what is to notice here is this is in terms of EQD2 because you add the dose from external beam to the brachydose. And here are the metrics. Again, the OAR, the D2TC. The thing to know about this is there are two dose constraints, one which is an aim and one which is a limit. The limit, you absolutely cannot go over it. The aim is it would be nice to be under that. And in more difficult cases, you will end between the planning aim and the limit. In terms of the dose to the tumor, the D90 gets looked at, and we want a total EQD dose more than 90 and still less than 95%. So there's a lot of dose constraints to follow. We've customized this to make an Excel spreadsheet which tracks both the 3 OARs and the target, and to be able to track it both with the external beam dose and with the brachydose from each fraction. As you give dose to each fraction, the sum gives you a reference to your aim and your limit. If we are on fraction 1, we'll simply assume that all 4 fractions have the same dose. So we can right from the beginning track what would be the total dose if we continued that way. This is how it looks in our treatment planning system. We have a little script that simply dumps the dose into that Excel spreadsheet and gives us live during planning the actual dose total EQD2 for the particular patient. So you get live feedback. So this is typically how the planning process happens. It is usually under the watchful eye of the radiation oncologist that I'm going to pass on now the next. I'm going to stop sharing.
So then I'll share again. All right. So for tandem and ovoid brachytherapy, brachytherapy is really essential for curative treatment of cervix cancer. And image guidance is really beneficial, both, the pre-planning with the MRI, the during procedure ultrasound, and then incorporating MRI for the contouring and planning. And then, hybrid brachytherapy is also very beneficial, but it's complex. And we found that 3D printed tools can really complement existing applicators and facilitate needle placement. So I'm just going to briefly talk about interstitial brachytherapy. So interstitial brachytherapy is generally combined with external beam for the treatment of either primary vaginal cancer or recurrent endometrial cervix cancer involving the vagina. And there's been population-based data showing that inclusion of brachytherapy significantly improves survival for vaginal cancer. At the same time, interstitial brachytherapy is quite complex and time-intensive. So many of you might be familiar with the SIAD. That's kind of one of the most common interstitial templates. So it's a template you attach to the perineum, but then you place the needles, as well as often there's a vaginal cylinder component. I just showed a couple other examples. So there's the MAC template and then the Kelowna template. But all of these kind of rely on placing the template kind of on the vulva or perineum area, often can be far from where a vaginal tumor is. Frequently, vaginal tumors are at the apex or the top of the vaginal canal. And once you've placed this template, you've kind of taken away the benefits of direct visualization. But when you have a tumor in the vagina, you can often see it with the speculum. So we were interested in making a template that allowed us to take advantage of direct visualization. So that we wanted to kind of maintain the other things that you have on the template, the ability to secure the needles, the ability to have a vaginal cylinder component, the ability to attach the template to the perineum, have it be MR compatible so we can, use it and get our MRI to help with the contouring, and then ideally sterilizable for repeat use. Because our thought was that, the existing templates kind of have you, blinded or blindfolded and inserting the needles far from where you want, and then needles maybe are veering and not going where you want. And if you could instead use the combination of direct visualization as well as still ultrasound, and then you're inserting the needles kind of at a short distance. So we developed what we call the Snap It, or Simple Needle Attachment Post-Placement Interstitial Template, which allows us to place the needles into the area of the tumor with, direct visualization as well as like transrectal ultrasound guidance. Then we place on the template and the needles are secured with the press fit locking. And then we have this additional locking cap. This template can accommodate a cylinder. It also has these suture areas so we can secure it to the perineum. It's made of PEEK material, so it's sterilizable and it's MR compatible. And so we actually, started using this template a few years ago, and we compared, using the Snap It versus traditional approach, and found that the procedures were about 20% quicker because it was a little bit easier with similar volume tumors. We still had excellent dosimetry, similar number of needles that were used, but the needles were inserted a shorter distance, right? So we're inserting more into the direct tumor as opposed to inserting sort of from the vulva or perineum and then crossing a lot of normal tissue to get to the area. At the same time, we recognize that not everyone is comfortable with inserting freehand needles into the tumor. So we've also worked on a 3D printed tool that we call the VIA, or Vaginal Individualized Applicator, that has kind of a standard design. There's a 2.5 centimeter cylinder design that can accommodate 20 or more needle guide positions that we individualize or customize based on the tumor topology or anatomy, so that we essentially use that pre-brachytherapy MRI for designing or tweaking the needles angles so that this will guide the needles to where we want them to go. And we found this can be particularly useful when you have a really large tumor. You essentially work on your initial alignment so that that central needle, is in the center of the tumor. Once you get that in place, then you can simply place the other needles and cover the tumor. And it really decreases the procedure time significantly with this approach, especially when you have a large tumor where you have a lot of needles to place. And so it makes the procedure much simpler, so less time for the patient under anesthesia. We've also found that this can be useful when we have, really bulky cervix tumors. So this is a patient that had, you know, you can see the uterus here, but it's almost dwarfed by this really large tumor. So when we did her pre-brachytherapy MRI, we put in a cylinder so that we could kind of plan this approach for designing the via to help add needles to cover this. And so we found that this is also useful for patients who have like a narrow vaginal canal and or a really large cervix tumor, so that we can adequately cover them and do it kind of in an efficient process. So the things that are kind of important about this, you know, this via is pre-planning, right? So the outside design is consistent but we have to really individualize the needle tracks so that we can adequately cover the tumor. Other things that are important is how we secure the needles. So as I mentioned, it can have over 20 needles. And part of our reason that we're able to secure so many needles is that we secure the needles a bit distally. So we use what we call this mega click. And again, it uses that press fit design and then with this additional locking cap. And by securing the needles a bit distally, that allows us to have, you know, a good number of needles, which also allows us to have some redundancy and flexibility in our design, so that, you know, we maybe aren't going to use all 20 channels, but we have different things that we can choose from at the time of the procedure, as, you know, what we see based on the ultrasound imaging. So overall, you know, brachytherapy is a really important part of treating gynecologic cancers. So the rapid dose fall off, you know, is really useful. And, you know, the areas that we're trying to treat, whether it's the cervix or the vaginal canal. So, you know, we use the vaginal cylinder for treating the vaginal canal. We're going to be using tandem and ovoid plus or minus interstitials when we're treating an intact cervix cancer. And then when we're treating either a vaginal cancer or a vaginal recurrence, we'll be using interstitial brachytherapy. And imaging is also really important, whether we're using, you know, the pre-brachytherapy MRI, the during procedure ultrasound, and then the MRI with the applicator in place to really be able to see the tumor and then optimize our planning. So I appreciate your attention, and Thomas and I would be happy to answer questions.
Yeah, we are opening the floor for questions. You can turn on your cameras if you would like.
Good evening, dear speakers. Thank you very much for the excellent presentations. I'm Dr. Sokolowska from Ukraine, and I have a few questions for you. First of all, have you used Smith's sleeve for the brachytherapy with the Fletcher applicator? And the next one, what is the best term for the start brachytherapy after surgery? With cylinder, of course. And the next one about recurrence. If we have recurrence after the previous treatment, whether external beam radiotherapy or the combination external with brachy, what the treatment strategy, doses, and fractionation? Thank you.
Okay. And so I might need reminders in case I forget the questions, but I think the first question was about Smith sleeves. So I generally don't use a Smith sleeve. So a Smith sleeve is something that's often put in by a gyn-onc into the area of the cervix to maybe make it easier to get in the tandem. I usually don't have too much issue getting in the tandem. As I mentioned, if I have trouble getting in the tandem, then I will use the transabdominal ultrasound to kind of make sure that I'm going in that track into the central, you know, uterine canal. It's just that in my experience, sometimes the Smith sleeve can be actually uncomfortable for the patient, right? So if you have dilation of the cervix, that can actually be uncomfortable for the patient. And I haven't had that much issue with being able to get in the tandems. And then I forget, the second question was about what kind of applicator we use after a hysterectomy.
No. What term after the
What
surgery?
is the time period?
Oh, the time frame? Yeah, so usually we wait at least 6 weeks after surgery before we do radiation. So for example, like your high intermediate risk endometrial cancer patient who's just getting vaginal brachytherapy with cylinder, we usually wait at least 6 weeks. We usually kind of aim for that 6 to 9 weeks. You know, if there's some sort of healing issue or something, Most of our patients are actually treated with like a robotic hysterectomy, where they often have very small abdominal incision, but you know, the vaginal cuff still needs to heal adequately, so we wait at least 6 weeks before we start that.
Okay,
And then
thank
the
you.
third,
We have the
okay.
same term, 6 to 8 weeks, and it's great period, I think.
And the third question was about recurrences, right? What do you
Yeah, if
do?
they've already had radiation, and they have like a vaginal recurrence, so there's a few things about that. So if you know, we want to see if, you know, it's important to do, you know, biopsy to confirm that it's actually recurrence, and then also imaging to see what the extent of disease is. Is the disease localized to just the vaginal canal, or does the patient have other disease? Generally, if the patient's already received, like, you know, if it's like a cervix patient and they've already received, you know, external radiation plus brachytherapy, and they have recurrence that's not just the cuff, you know, or just the cervix, they would get systemic therapy because of the fact that, you know, you can't really do retreat to the whole pelvis. If it's somebody who has just a recurrence, or like maybe say you have somebody who just had pelvic radiation, or, you know, just had vaginal brachy, what we think about is how far out are they from treatment. Ideally, you want them to be farther, like the farther out, the better they'll do. I think sort of usually if they're just an isolated recurrence, the standard of care would sort of be an exenteration. But if for some reason the patient doesn't want an exent, or they're not healthy enough to undergo an exent, we do sometimes do reirradiation with interstitial brachytherapy. Generally, what I do in that case, where I'm doing just brachy only, because I think with brachy is your best thing to do as opposed to external beam, just in terms of dose fall off and you know, what you can do for normal tissues. So not that long ago, I treated a lady with cervix cancer, who had cervix cancer in the past, got treated with surgery and then external radiation, and then she had a recurrence in her vaginal canal, and that was the only site of recurrence. She didn't want to have an exent. And so the dose I use is I do 6 gray times 6 to that tumor area. I generally do 2 separate treatments. So I do essentially 3 fractions per treatment. So I do, you know, 1 insertion, treat, keep overnight, treat again that next re-image to make sure nothing has shifted, treat again, and then treat another 6 hours later, and then remove the applicator, and then she'll come back a week later, and we repeat that same process for 6 total treatments. But there is, you know, some debate about, you know, there's different doses. Some people, and you know, some people, it depends what you feel comfortable with in terms of what dose they've previously received.
Yes,
but yeah, I think probably the standard is surgery, but then there's certain situations where surgery is not an option, so you could think about reirradiation, but you really want to counsel them about the risk of toxicity, because, you know, with the reirradiation in that setting, the toxicity risk is higher. I think the studies kind of show something around 15%.
Thank you. And may I have the last question?
Oh, sorry, I just want to comment on that Smith sleeve question. So Dr. Kidd uses titanium applicators. So these have they're rather thin. They are 3 millimeter diameter. Typically, plastic one is 6 millimeters. So there's less of a need to use a Smith sleeve.
Okay, thank you. May I have the last question about full obliteration of the cervical canal? What we should do in this situation, and what your attitude to the external boost? Maybe it's reasonable in this situation.
So how long of the cervical canal do we treat? Can you repeat the question again?
The full obliteration. If we have the full obliteration and the central tandem couldn't be placed in the cervix.
If you're having difficulty placing the tandem, is that what you're saying?
Yes, yes.
I mean, so I think the thing that's most helpful if you're having difficulty is the transabdominal ultrasound, because then you can see if it's going in the uterine canal as you're placing it. So I think that's kind of the most helpful. You may also be able to get like a gyn-onc to assist with like the placement. I know like here we generally do the procedures, you know, without gyn-onc, but I know some institutions do the procedures with a gyn-onc who does assist with placing tandem. So that I guess would be, something to consider if it's difficult to place, or if, you're at it, like if you're at a, like an outpatient setting where the gynec can't do the procedure there, they could do, like you mentioned, placing a Smith sleeve in their OR, and then the patient comes to you for a subsequent procedure where they already have that in place.
Any other questions? But I have a question about patients being inpatients or outpatients. Can you comment on that for TNO and also for cylinder treatments?
So our cylinder patients are all outpatients, so they're just usually here for a few hours, 2 to 4 hours. And I'd say our TNOs are also generally outpatients, although it's a longer procedure because they're here with, they do the procedure done under anesthesia, so they have to arrive early, and then there's more recovery time. Very rarely do we keep a patient as an inpatient with the tandem. So we do keep the interstitial patients overnight, but for the tandem and oval patients, we generally don't keep them overnight.
So they all go home, right?
Mm-hmm.
After procedure. That's amazing. And for Thomas, Thomas, can you please comment on the process for designing the applicators?
So we now use effectively what is a standard design for TNO, so this target effect. Just from clinical experience, we've narrowed down where the needles need to go and what options we need. So typically that is a standard design. In 15% of the cases, we need to customize it. And the way we customize it is either from the pre-MR, the contour would be imported into the design software and customize the needle direction, or from the first fraction, if that was not a satisfying needle location, we can then customize to the patient again using the contours and importing it into the CAD software. And the whole process, from designing to having something in your hand and sterilizable is 2 days. So in our case, we can design from fraction to fraction as needed.
Thank you. There's a question in the chat from Natalka Sukhoverska. All the 3D printed applicators printed in PEEK. Is this for strength or to enable sterilization? And how many times can you sterilize the PEEK applicator?
So they are 3D printed. Oh, go ahead.
No, so you can take this one.
So there's a number of 3D printers which make sterilizable and biocompatible materials. PEEK is one. We don't have a PEEK printer, but I know other institutions that do. We use a 3D printer that is from a company called Forms Lab, and the material has its own special name. And typically we make Biomed Clear, thank you. And typically we print one device for each patient. So every patient gets their own print, and we can sterilize for all the fractions. So we'd sterilize 4 times and then throw the applicator away. But PEEK is a great choice if you have a PEEK printer.
Excellent. Any other questions?
May I ask a question?
Yeah, go ahead. Yeah.
I would like to ask if you record or control dose to vaginal wall. And also in your example, you use, I think, spacer between rectum and vaginal wall. So is it normal practice to use it all the time, or it was just some example?
Yeah, so I don't specifically track the vaginal bulk dose. In my planning, I do pay attention to hotspots, so I don't like hotspots on the vaginal mucosa. And then historically, it's been found, or I think it's the Jackass group found that the historical rectal point corresponded to sort of vaginal mucosa dose, and that rectal point actually sort of corresponds fairly well with, your hottest part on your, where you track your rectum dose as well. So I think by sort of tracking your rectum dose, by paying attention to your hotspots, tracking your rectal dose, you kind of pay attention to that. And yes, generally for our tenement ovoid procedures, we use the lattice balloon posteriorly, so kind of behind the ovoids, and then we use packing anteriorly.
Thank you.
Any more questions? Beth, if you don't mind, if you stop sharing, we can maybe take a group photo. If people turn on their camera, we can take a group photo. Please turn on your camera. We have a great attendance today. I think at the peak, it was 106 people attending. Excellent lecture. Thank you so much. It's night in Ukraine right now. So smile for the photo. Excellent, I got it. Thank you so much. See you then Wednesday. Thank you, Beth. Thank you, Thomas. Bye, everyone. Slava Ukraini.